Welcome. So today, thanks for having me present. Today we're going to talk about reproductive health and menopause for women living with HIV. So I have a smattering of topics, and it's not all on menopause, but some things to consider for women in regards to their reproductive health and the menopause transition. All right. So I'd first like to acknowledge that I live, work, and play on the unceded traditional territories of the Coast Salish peoples, including the Musqueam, Tsleil-Waututh, and Squamish nations. And this is a picture from beautiful BC, near where I live. And I'd like to also acknowledge, with respect, all of the lands and waters across Turtle Island, from which people are joining today, and the traditional Indigenous peoples of the lands and waters, who have been custodians and carers of this land since time immemorial. These are my conflicts of interest. And I guess I would like to just start by saying, as many of you may know, that women make up more than half of the world's population of people who live with HIV, about, a little over 50%. And though in North America, for instance, that proportion is smaller, it's approaching 30%. In places such as sub-Saharan Africa, it's actually about 2/3 of individuals. But research really only about 8% of research is done in women particularly. And so when you look at women living with HIV, there's definitely not enough. And so we need to do more, particularly because half of the people in the world who live with HIV are women. And one of the major things that sets women apart from men, okay, is, and I guess I'm speaking, when I'm speaking women in this context, I'm speaking about cis women, so females, okay, is that they may have higher rates of infertility, lower pregnancy success with reproductive technologies than people who don't live with HIV, higher rates of irregular menstrual patterns, increased rates of amenorrhea, which is losing your period for prolonged periods of time before you get into menopause, and not due to pregnancy, breastfeeding, birth control, that sorts of thing. There are some papers that suggest there's an earlier age of menopause for women living with HIV, and there's some data to suggest that women living with HIV have more severe menopause symptoms. So there's been some studies out there that show that there's some differences for women living with HIV, and these are important things to consider and to ask women living with HIV about as we care for them. And when you look, so this is again, so we're talking about females here in this particular instance. This is the hormones, basically progesterone and estrogen. So estrogen is spelled with an O because this is from the UK and that's how they spell it, okay? But everywhere else you're going to see it without the O on the beginning. And this is a caricature of what the hormones do throughout the life course. Okay, so progesterone and estrogen are two female hormones, although men have them too. So males have them too. So really every human being on earth has some level of these, all right? But they're the ones that are needed for fertility for females, okay? And you can see in puberty, they kind of start out kind of bumpy. And for the women in the group here today, you may, remember those days when you were going through puberty and just starting to have your periods, how things might have been pretty erratic and all over the place. And that is shown here as the levels kind of sort themselves out. And then you come and you have your peak fertile years. So the years when you're most likely to get pregnant, if you choose to. And at that time, your levels of progesterone and estrogen, though they fluctuate throughout your cycle, are much higher. Then we get into perimenopause, which is the time when things start to change. Okay, so this can happen as early or even earlier, but very classically can happen starting in the early 40s to mid 40s. And that's characterized by change. Your periods start to change. Maybe they get closer together at first and then farther apart. They might get heavier and then lighter. And they might be just all over the place. And that's associated with other symptoms as well, such as hot flashes sometimes and sweats and things like that. Okay, but you can see that the hormone levels are fluctuating quite a lot. They're kind of all over the place, up and down during that time. And then they kind of fall when you hit menopause. So menopause is when your periods stop. And typically we define menopause as having had no periods for 1 year, and that's not due to pregnancy, breastfeeding, birth control, surgery, or chemotherapy, those sorts of things. Okay. So when those periods stop for more than 1 year, that's menopause, and you can see that the hormone levels become a pretty steady state that is then much lower than when you were in your fertile years, and that goes on kind of through your later life. The normal menstrual cycle for a fertile female, you can see the estrogen and progesterone levels, they go up and down, okay? And so the estrogen is higher in the first half of the period. So if you have a cycle that's 28 days, which is classic, it might be longer, might be shorter for an individual, but you can see the estrogen is higher in the first half and then goes down and kind of smooths out over the second half, whereas the progesterone kind of climbs and is higher in the second half of the cycle. And the LH and FSH are two hormones that the brain puts out that are telling the ovaries when to have the progesterone and estrogen expressed. Okay, so they're giving signals from the brain. Okay, so that's what a normal menstrual cycle looks like. But we do know that women living with HIV have more prolonged amenorrhea. So no periods for a year or more, okay, not due to pregnancy, breastfeeding, birth control, that sorts of things. So more of that than people who don't live with HIV. And in fact, Liz King, who many of you will know, did this study a few years back, which looked at studies out in the literature that had looked at, periods of periods of no menstrual periods, and found that indeed after you look at all of them, you put it all together and you control for all the things, women living with HIV have about a 1.7 times higher risk of long periods with no menstrual periods in their lifetimes. And the importance of this is that it is associated with lower progesterone and estrogen. Okay, so lower hormone levels in their body at these times, in most cases, not all, but most cases. This is one of the studies that was out there. This is by a big cohort in the United States, and they had over 3,000 women, and they looked at the different reasons for amenorrhea in their cohort. And you can see contraception was a common one, but things like opiate use or substance use. So substance use is about 20%. Psychological medications. So some of the medications people take for mental health can do it. Cancer diagnosis in a small proportion of people. And then many of them, they didn't really know what the cause was. But things like stress and food insecurity can also cause periods to stop. And the reason why periods stop for women when they're in their fertile years is, the body saying this is not a good time to get pregnant. Okay. And saying, you know what, we're going to shut this down for now because it's not a good time to get pregnant. Okay. And so other reasons, a low body mass index. So if your weight is too low, that's another reason why this would happen. Okay, and another member, so Shada Swan, who was a PhD student with us, who just recently finished, she looked in the BCC3 study, so the British Columbia Karma Chiwo study, and the Karma study, which came before it, and looked at women living with HIV and negative controls and causes of this long periods of no menstrual periods in their lifetimes and what was going on, and found that in our study as well, even controlling for other things, living with HIV meant that women were more likely to have periods where they didn't get their menses. Okay. Substance use also was a big player. And as you got older, this was more likely to happen. Okay. Food insecurity was important. And we know that body mass index, so how much you weigh is important. And body mass index is a measure of how much you weigh compared to your height. Okay. So it kind of, it's not perfect, but it standardizes people by their height. Okay. And income and tobacco smoking can also affect things. Now, why is it important? Why is it important that we figure out if people have long periods of time without their menstrual periods? Like, what's the importance of that? And I guess the thing is, with amenorrhea, like I said, most of the time, not all, but most of the time when people have these long periods without their menses, it is related to their brain not putting out those chemicals that tell their ovaries to make estrogen and progesterone. And so those levels end up being very low. But we do know that estradiol, which is the main estrogen that women have in their fertile years, okay, is very important for maintaining and building bones, for kidney functioning and prevention of kidney disease from moving along. It's protective of the liver and good for liver function. It protects the heart and protects you from hardening of the arteries. It's protective against metabolism, so protective against diabetes and weight gain, and protective of the brain, protects against Alzheimer's and decline in your mental functions, okay, and against depression. And there's also data to suggest that other hormones, other sex hormones, including estrone, which is the major estrogen that women have after menopause, progesterone, okay, and testosterone, as well as cortisol, that these are also important for many of these body systems. And it's important to note that, like I said, so males have estrogens and progesterone, females have testosterone as well, lower levels, but we do have some. Okay, and everybody has cortisol. So some of the things that have been shown in the literature to be important is that low estrogen levels, okay, caused by a lack of menstrual periods, okay, will result and has been shown to result in accelerated atherosclerosis, which is faster hardening of the arteries, okay, particularly in women before menopause. Increased osteopenia, and that means lower bone mass, which means a higher risk for breaks in your bones as you get older, okay? Increased depression and anxiety, all right? And cognitive impairment, which means trouble with memory and mental functions as you age. And something called immunosenescence, which is the immune system kind of getting tired and not working like it used to. Okay, so all of these are associated with low levels of estrogen. And so, if you have long periods of time without your menstrual periods in your fertile years, you can imagine it's like going through menopause earlier and will have all the potential effects of missing those hormones as we age. Okay, and so this is a paper by our group, again by Liz. Liz was pretty productive during her postdoc, that showed that women living with HIV who had normal menstrual periods, okay, had higher bone density than women who didn't, and you didn't see the same correlation in women who weren't living with HIV. The women who weren't living with HIV had better bone mass than women living with HIV, and that's a different story. We can see that not having your periods makes it even worse. So it's really important to make sure that we do something about that. So what needs to happen? So if you're a physician, you need to ask your patients about their menstrual periods before they get to menopause. If you're a patient, if you're a woman living with HIV, you need to tell your provider about your menstrual periods. And if you're not having them, you need to ask, okay? And that can be a barrier, I know, because not all providers are comfortable talking about that. But that's something that we need to, I think, as a group, help to get those providers to be comfortable so that they do ask and they do help if you're not having them, okay? And if a woman doesn't get her period for 3 months or more and isn't over the age of 45, so over the age of 45, if you're not getting your periods, that's considered the normal time of menopause, so it's less worrisome, okay? But if you have no periods for more than 3 months and you're under 45, that really should get looked at, okay? And the first thing is, are you pregnant? So even between 45 and the early 50s before menopause, women can get pregnant. So you might not think you can get pregnant, but even if your periods are erratic, sometimes there'll be an egg that'll get out there and someone could be pregnant. So make sure to check if you're pregnant. Okay. And then if not pregnant, but still missing your period, then a provider should do some testing to see what's going on. Okay, so something to discuss with your provider, to reach out for help if you're having trouble navigating that, and for us to teach. Okay. All right, and that's just some of the ways that we define things. So if a woman doesn't have, or a female doesn't have her menses for 12 months or more, and we see those hormone levels, so the estrogen and the progesterone are low, but the signals from the brain, the FSH and LH, that tell the brain to, hey, make progesterone and estrogen, if they're high, it means that the brain is trying, but the ovaries they're tired, they're done. Okay, so that suggests menopause. All right, if a woman is over the age of 45, that's normal. All right, it's a normal age of menopause. But if a woman is under the age of 45, it's early menopause. And if she's under 40, that's something called premature ovarian insufficiency. And certainly for a woman under the age of 45, there's a very clear indication that she should have hormone therapy if she wants it, at least until the age of menopause, at least until about 50, 51, so that she doesn't have those years without those protective hormones that are protective, again, for all those organ systems. Okay. And then if that's not the case, and the estrogen, progesterone are not low, or the FSH and LH are low, suggesting that the brain's not sending out a signal to tell the ovaries to make hormone, then if the root cause can be addressed to try and get women to get their periods back, then that is important to do. So that's something for the providers in the room, okay, but also for women living with HIV that have this going on, to ask their provider about. All right, so the menopause transition. Menopause is a natural part of aging that is unique to females, right? It is actually really interesting why they think that menopause, why scientists think that menopause happens. And one of the things that is thought as a reason for menopause for humans is that grandmas are important. Okay. And so females over the age of 50 or so who enter menopause aren't then concerned about raising their own infants anymore. And they become concerned about their grandchildren, about the generation coming behind them. And they help their children to raise their children. And there is some data to suggest that that role of the grandmother actually enabled more grandchildren to survive and to live. And so it's a really neat and empowering and an important reason why women go through menopause. It's a moving into the next stage of looking after your, the ones who come after you. But menopause comes with it, the loss of the hormones, right? The loss of the estrogen and the progesterone that protect all of these organ systems pictured here, right? So your kidneys, your liver, your heart, your bones, your brain. And so as we lose those protective hormones, we then start to see more aging, and we kind of catch up to the men after that time. All right, the menopause transition. So the hormones, I showed you earlier how in the fertile years, the estrogen and progesterone are higher, as you see on the left-hand side, and then, start to fall with perimenopause. And the progesterone tends to fall more like this, whereas the estrogen can really be all over the place, and it can actually be higher than it is sometimes during the fertile period. And that is part of the reason why women have the symptoms they have in the menopausal transition. Okay. As you move into menopause, as you see those levels of hormones, they drop. And I thought that this caricature that I found on the internet was maybe a little bit brash, but fairly accurate in some of the things that people might experience. Okay. So normal productive life, I don't think I like that. Fertile period is premenopause. Okay. And women, as they cycle and have their periods, as many people would know, irritability, cramps, can have mood swings, things like that. After the last menstrual period, the last regular menstrual period, we probably don't know when that is, right? No one can probably look back and remember when the last normal menstrual period was, because they just seem to kind of get further apart or closer together, and they kind of change slowly over time. But women in the perimenopausal transition, okay, in that time, can experience irregular periods. Sometimes they're heavier, sometimes they're lighter. Weight gain is very common. Joint pains, night sweats, hot flashes, loss of libido, okay? Depression, irritability. So all of these things can kind of happen and start to happen as women progress through perimenopause. And then menopause, that last period, okay, is menopause. And, when the periods stop 1 year after that last period, you're considered to be menopausal. And as you progress through that time and your hormones fall, the tissues that had estrogen and progesterone helping them all those times, they lose that. And so some of the symptoms we experience later would include vaginal discomfort or dryness, urinary tract infections, and then increased risk for those things that estrogen protects you and progesterone protects you for, such as osteoporosis and heart disease. All right, so the symptoms of menopause, talked about them a little bit. So the hot flashes and night sweats, aches, weakness, stiffness, joint pains, okay, constipation and gas, skin and hair changes. So skin might be drier, hair might be drier, poor sleep. Some people start having sleep apnea, which is kind of when you stop, you snore, you stop sleeping. Weight gain, very common to have a several kilogram weight gain with menopause that is kind of hard to fend off. So all of these things can kind of come along with menopause. Okay. And then some of the circles that I didn't talk about are the genitourinary symptoms of menopause. So these are the ones: the inflamed or irritated urethra, the vaginal dryness, the urinary incontinence. These are the ones that happen locally, okay, in around your reproductive organs, okay. And so women will often experience irritation, dryness, or itching. They may not have enough lubrication, and so may have pain with sex. May find that they're dry, or that sex is uncomfortable. Women may experience pain with urination. They may have leaky bladder, hard to keep the urine in, especially if you get on a trampoline or try and do jumping jacks. Recurrent urinary tract infections, and or vaginal or vulvar pain. And vulvar kind of is the skin on the outside of the vagina, okay? And cognitive mood problems, or symptoms such as depression, anxiety, sleep troubles, so waking up in the middle of the night, feeling more irritable, or having trouble concentrating. These are all very common symptoms of the menopause transition. What about sex? So I mentioned that sex may not be as comfortable. There may be more difficulty with lubrication, but actually we have a little, this is preliminary data from BCC3 studies, so the British Columbia Karma-Chiwo study, which looked at sexual satisfaction among women living with and without HIV. So WLWH is women living with HIV. And what was nice to see was that sexual satisfaction was about the same in women living with HIV and HIV negative women. HIV doesn't get in the way of that. And, there are things that we can do to make, sex more comfortable, vaginal estrogen creams, for instance, or tablets. And pleasure doesn't need to be impacted. Okay. The biggest impactor on sexual satisfaction for women in our study was household income, with people having more than $20,000 income being associated with higher pleasure. So financial stress being the most important one. And interestingly, sexual pleasure in women before menopause, the biggest thing was whether there were children in the home in our study. So it has nothing really to do with hormones so much as it does to what's in our heads. All right. Similarly, genitourinary symptoms of menopause, so the bladder leaks, the vaginal dryness or irritation, those things, again, similar in women living with HIV and HIV negative women, okay, when we look at it. So that is good. It doesn't seem that there's any really role of HIV in making these particular things worse in our study, at least. Okay. But I think one of the things that's really important is that many women that I've talked to say that, their family doctor isn't comfortable providing menopausal hormone therapy for them, or because they don't know about interactions with medications. And their HIV care provider isn't either, because they don't know how to do the prescribing of menopausal hormone therapy. And so when you put those two together, sometimes women living with HIV fall between the cracks and they don't get offered menopausal hormone therapy because neither person knows quite what to do. Okay. And so there is some data to suggest that women living with HIV are less likely to be offered or to be on menopausal hormone therapy than women not living with HIV. And that's something we can definitely do something about. Right. So the indications for menopausal hormone therapy are relief of those vasomotor symptoms. So the hot flashes, the night sweats. Okay. If women have the thing called premature ovarian insufficiency, which is when their periods stop before the age of 40, or really even before the age of 45. To relieve those genitourinary symptoms, the vaginal dryness, the itchiness, the bladder stuff. Okay. And to prevent bone loss, but they say that that's not enough alone. These are the guidelines put forth by the gynecologists in the room. Okay. And then reasons not to give hormonal therapy as a treatment for menopause would be unexplained vaginal bleeding. So if you're having bleeding after menopause, so after you've gone a year without periods and everyone says, okay, you're menopausal, if you then have vaginal bleeding again, one of the things that we worry about there is endometrial cancer. Okay, it can sometimes have vaginal bleeding after the fact. And so that really needs to be worked up and figured out before you could have hormones, because we don't want to feed a cancer. Okay. So if you have that, you got to figure that out first. Okay. If the liver suddenly doesn't work, okay, that would be a contraindication. High risk of VTE. Now, VTE is clot. Okay. So if you've had blood clots in your legs or in your lungs before, okay, that would be a reason not to have the hormones. If you have a history of breast cancer or endometrial cancer, if you have known coronary artery disease, so known blockages in your arteries in your heart, known dementia, or your brain not working so well anymore, and high triglycerides, but they don't say how high that is. And triglycerides are one of the things we measure when we measure cholesterol. And so if those are really high, then that would be a relative reason not to give hormone therapy. Okay. And then the other one that's a relative one is after the age of 60 or 10 years or more after menopause. It's kind of a bit too late to offer menopausal hormone therapy. And it's not an absolute, okay? But what they found in one of the big studies they did of hormone therapy for women, for females after menopause, was that women who were over the age of 60 or more than 10 years after menopause were the ones most likely to have more bad outcomes, heart outcomes, okay, than women who were younger when they started therapy. And so the risk of it actually causing more heart problems is higher if you wait too long. If you do it right away or before 10 years, actually the risk of heart disease is lower if you use hormone therapy. Okay. So that's one of the reasons. All right. And then so for prescribers, you want to check for drug-drug interactions. When we're thinking about contraception, so medications to prevent pregnancy, the drug-drug interactions are really important, because some of the hormones that you might take, like a hormone contraceptive pill, okay, they don't work as well. And so they might not protect you against pregnancy because of drug-drug interactions. But we have much less concern about that with menopause hormone therapy, because we really are just trying to improve your symptoms. And if you end up with a lower level, then maybe you just need to change that level a little bit. We're not going to get a pregnancy that we didn't expect. And so there's less worry about that. Okay. But some other things that prescribers have to remember is that if a woman has a uterus, if a female has a uterus, then estrogen and progesterone have to be used together. Okay. And that the benefits and risks have to be considered. So this is speaking about hormone therapy in particular. And so the major risk to hormone therapy for postmenopausal women is a slightly increased risk of breast cancer. Okay, it's real, but it's small, but it's real and it's there. And so if you have a strong family history of breast cancer, you may choose to do something alternatively. But if you don't, you may take the risk, and the risk is greater the longer that you use the hormone. So you may want to use hormones for a little bit of time, and then every year have a discussion with your provider about when you might stop, or if you're just going to stay on it forever. Okay. The lowest effective dose for your symptoms is what should really be used, and you should discuss it with your provider each year and see how you're doing. Okay. There are other alternatives, though, to hormone therapy that a woman would take for her whole body. Okay, a female would take for her whole body. And those include things like vaginal estrogen creams or tablets, antidepressants. So medications for mood also can help with menopause symptoms. Medications like clonidine, gabapentin, or pregabalin, also known as Lyrica. So these are ones that we often use for nerve pain. It can also have some help with some of the symptoms that women have, as well as cognitive behavioral therapy. Someone's got something in the chat. So Peggy's just putting in the chat that I wonder if women who are between the ages of 45 and 55 would benefit from more frequent appointments or discussions with care providers, as access to and timing of initial hormone therapy seems to be critical. So I think that it's a really good point, and I think that it should definitely come up, especially in this period of a woman's life, right? This is something that should be discussed with each visit, ideally, right? And what their needs are at the time. And timing, so it's not an emergency to start therapy, but you do want to do it before too much time goes by if women choose to do it. Does that make sense? So yeah, so we can discuss it a little bit more, but yeah, I agree. Every visits should include this as part of the things on the part of the list of things that are talked about. All right, and this is actually out of a paper that was done by a number of people who provide HIV care in Canada. And it looks at interactions between for the medications that are available for menopause hormone therapy or menopause symptom therapy, okay, and antiretroviral medications. Okay. And so, vaginal estrogen creams, rings, or tablets, really, there's some yellow there, but really they work very well, and they don't really cause too much trouble at all with antiretrovirals. And in fact, if anything, it's just the estrogen component of those rings that is affected. And so these are things that we can work with. Okay. The medications that I talked about, so like the clonidine, gabapentin, pregabalin, those ones, so the antidepressant medications, they're actually pretty good. It's not the antiretrovirals so much that are affected as it is the medications themselves. So often you can change dosing as needed to kind of make up for that. Okay. There is one desvenlafaxine, which I don't think I've ever used, which doesn't play well with atazanavir, doravirine, or rilpivirine. Okay, so that would be one to watch out for, but otherwise, they're pretty good. All right, and when you're looking at these other ones here, so hormonal therapies, these would be all options that are taken internally or used as patches. And again, the effects are mainly on the hormones themselves. And so with a little bit of exception, mainly on the hormones themselves. And so they can be tweaked or changed for symptoms. I do want everyone to take a look at the natural health products at the bottom. And so this is not it wasn't done for all the natural health products, okay, but it was our pharmacists at the time looked through the literature to see what was available for the different natural health products, to see what interactions there might be, okay? And so this is the data that was findable at the time. So black cohosh can be used for menopause Symptoms, okay, so just there was a caution there about hepatotoxicity, which is liver troubles when you use antiretrovirals together. Okay, so that was kind of all across the board. So just closely watch the liver enzymes, I guess, if you're going to use those together. Chasteberry, dong quai, and wild yam. There's very little information to know if there's interactions. So again, if you're going to start one of those, and do it cautiously and monitor, make sure the viral load's okay, make sure symptoms are okay. Okay. Evening primrose oil would be a very common one. And it is, pretty okay for the integrase inhibitors, the NNRTIs, so doravirine, rilpivirine, etravirine, these ones. But the protease inhibitors such as atazanavir, I can't speak, darunavir, ritonavir, or things like that, shouldn't be used together. So if you're on a protease inhibitor, not a good idea to use evening primrose oil. Okay. Fennel and red clover, again, so we're seeing here the integrase inhibitors could be increased a little bit, right? And that may increase side effects, all right, of those antiretrovirals. So just something to think about, all right? Soy does not play well at all with etravirine. So don't, while you can have soy products in your diet, taking something that is from the health food store, be careful about that. And then valerian, also a commonly used medication for menopause therapy. It does not play well with antiretrovirals in general, so to be careful about that. And I believe St. John's wort is also a problem if anyone takes that for symptoms. For more information about menopause, symptoms, menopause therapy, and kind of navigating menopause for women living with HIV, there's this wonderful pamphlet that was made by Leanne Flinton. She was a student of Liz King's and many of the other members of the BCC3 team. You may see yourself in the circle of authors in the middle there. And it's a document that really was made with women for women living with HIV who experience menopause, to kind of help guide you through and give the pamphlet is really good. It even has some ideas on how to broach the subject with your physician, okay, and have the conversation so that you can get the care you need to navigate menopause well and in a healthy way. Okay, and so these pamphlets, this is just a screenshot, but it's a whole little pamphlet, little booklet. They can be ordered on the Katie website, and we do have them at Oaktree as well. So what about screening? I'm taking too much time. Okay, so I'm going to go through this quickly. There's a few things. So speaking about reproductive health of women, kind of as we go through life, there's cervical cancer screening, which many people be familiar with. So this is looking for cancer, usually not always, but usually caused by the human papillomavirus, the HPV virus. Okay, and primary care guidelines to date have stated that women should have a PAP when they start care after 6 months, and then if those are okay, then every year. Okay. And that's because PAPs that are abnormal are more likely in women living with HIV versus the general population. Okay, and the lower the CD4 count is, the more likely there is to be an abnormal PAP. Okay, and HPV infection is related. But in British Columbia, that's recently changed, and I'm hoping that the rest of the country will soon follow. I don't know if other provinces have changed to this yet, but we did earlier this year. And so what's wonderful about this is that women can actually go online and order their own self-screening kit, and they get what looks, the tube on the right-hand side. It's a swab in a tube with instructions, and you do a vaginal swab as per the instructions, and you actually put your name on it and pop it back in the mail and get your test done. Okay, you can also do it in your clinic. So we're doing it in the clinic with women. They can do it themselves, do the swab themselves in the bathroom or in the exam room, or the nurse practitioner can, or one of the physicians can help them. Okay. And if the test is negative for HPV, it looks for HPV particularly. If it's negative, a woman doesn't need to be screened for another 3 years. So women living with HIV, 3 years without having to have a PAP. Yay. If it's positive, then it means you do need to go and have an exam. But I think it's really wonderful, a wonderful change, and I'm hoping it'll be available throughout the country soon. Okay. And then the other thing that's come up for us recently in British Columbia and was presented earlier this year at meetings was HPV and its relation to anal cancer. Okay. And this, there was a paper put out by Anne Burchell last October that showed that people living with HIV have, so that's a lifetime risk of anal cancer by the age of 65. Okay. So this is not later in life, but by the age of 65, of 1.8% if they're a person living with HIV versus 0.02%, okay, if they're not living with HIV. So they have almost 100-fold increased risk of anal cancer by the age of 65. And much of this is occurring after the age of 45. So as women are going towards menopause, this is something that's becoming important. Okay. And that dovetails nicely into these new guidelines on anal cancer screening that came out in May of this year. And the new guidelines suggest that people who live with HIV, so if you look at risk category A, okay, this is a cancer incidence. So that means the amount of cancer each year, okay, is more than 17 per 100,000. And that is people living with HIV. And it's not just men who have sex with men. Okay. So, it's got here men who have sex with men or transgender women over the age of 35. Okay. Just because of potential exposure to HPV. Men who are not MSM, who are 45 and over, and women who are 45 and over, who, not cis women who are over 45. Okay. Or anybody who's had a history of vulvar dysplasia or vulvar cancer in the past, people who are MSM or transgender women not living with HIV over 45, and people who have a solid organ transplant. And then there is people who have a history of warts and things like that is lower, but you can discuss with your doctor. And the type of screening they're suggesting is a digital anal rectal exam. So the provider, I see there's a couple of comments, I'll try and hurry. The provider takes their finger and examines, puts their finger just inside and examines for any lumps or bumps or any abnormalities. Okay. So that if there's nowhere to do other screening, that's one way to do it. Or to take a swab, kind of like doing a pap test of the anal canal and send that off to see if there's abnormal cells or if there's HPV. Okay. And if those are abnormal, to send people for endoscopy if it's available. Okay. And that should be done every 1 to 2 years. That's the new guideline. All right. And that leads into the fact that most of anal cancer is caused by HPV, and that HPV vaccine is now indicated for all women 12 to 45 years of age. And so everyone who's not vaccinated should be. Okay. And then finally, breast cancer screening is the same as for the general population. But let's not forget, again, there's this, paucity of primary care providers potentially thinking about these things because of, they don't want to get in the way of the HIV care provider, and the HIV care provider not thinking about it because it's not they're an infectious disease doctor, for instance. And so something to remember, it's important for women to get to their breast cancer screening. And we see increased rates of breast cancer in Canada over the last few years. And so everyone, ideally everyone over the age of 40 should be going for screening. Okay, so that's all I've got. It leaves us a few minutes for questions.